Hello and welcome back to episode 6 of the Rehab and Exercise and Sports Therapy podcast. I am fortunate enough to be joined by Dr. Dave Sherman from Northeastern University, who is heavily engaged in some research activities that impact us on a daily basis with our rehab. So, Dr. Sherman, if you could give us a little bit of background about you and what some of your research interests and projects are.
Sure, Dan, thanks for having me. I'm Dave Sherman. I'm a physical therapist and athletic trainer, originally from Cumberland, Rhode Island. Good to be back here in Rhode Island for this podcast. I went to Boston University for my undergraduate in athletic training and doctor of physical therapy degree, and then moved to Fort Worth, Texas, where I worked as primarily sports medicine outpatient physical therapist, treating patients with post-concussive syndrome and after ACL reconstruction. Based on the clinical outcomes I saw in that practice, it inspired me to go back and study further and get a PhD researching muscle inhibition as it comes to post-traumatic knee injury. So patients after ACL injury or meniscus injury or even knee osteoarthritis. I did that at the University of Toledo in Ohio, where I applied a mobile brain imaging approach to study muscle inhibition in the quadriceps and rehab interventions that we can use to apply to address it. I find myself after 2 postdocs in the Boston area working now at the Northeastern University, where I'm appointed in the physical therapy department and the College of Engineering, where I continue to study muscle inhibition interventions to address it and the development of new technologies that we can translate to help clinicians in their practice.
Great. Thank you. So for some of our audience that may not be as well versed in neuroscience, if you could just give us a little bit of background about arthrogenic muscular inhibition, since it is, as physical therapists, it's kind of the bane of our existence for anybody that treats knee injuries on a daily basis, right? If you could give us a little bit of background about how AMI develops following knee injuries, and also how it relates to kind of subsequent surgeries.
Great. Yeah. So arthrogenic muscle inhibition has become a bit of a hot topic lately in rehab. I think because we as clinicians are getting better at recognizing that the weakness we see after knee joint trauma is not necessarily associated with, or not necessarily the same as weakness that we see in deconditioning or immobilization, for example. What arthrogenic muscle inhibition is it's an autogenic reflex response that occurs from sensory neurons as they interact with the alpha motor neuron pool at the level of the spinal cord. When I look back in the literature, this is not a new phenomenon. It was the first publications I can find with it referenced are in 1925, 99 years ago. In the first paragraph of that publication, Dr. Barrell talks about Hippocrates and how Hippocrates actually described this in patients with arthritis or swollen joints. So the way the nervous system is wired, when we have swelling or pain arising from a joint, that enacts an autogenic reflex pathway that prevents the alpha motor neuron from fully contracting the muscle on the same side of that joint. In this case, we see it a lot in the quadriceps muscle after ACL injury or meniscus tear, or specifically, it's most pronounced, I think, after surgical intervention where the knee is most swollen and painful. But it occurs potentially at any joint.
Okay. If you could give us a little bit of background, what's the time frame? When do you see these changes typically onset, both at a local joint level and then also kind of looking more macro? When do we start to see some changes kind of at brain level or upper central nervous system?
Yeah, it's a great question. So we know the nervous system is composed of many different parts. The most crude way to divide it, central nervous system being the brain and spinal cord, peripheral nervous system being the nerves in the periphery and in the limb. Arthrogenic muscle inhibition starts in the periphery. It is overactivation or sometimes damage or deafferentation of sensory receptors within the joint, being cartilage, the joint capsule itself, or the ligament in the case of an ACL injury. So it's going to begin at the time of injury, continue and be exacerbated at a second insult being surgery, and then continue, at least at the level of spinal cord, the way I define arthrogenic muscle inhibition, until pain and swelling is resolved. So if you're dealing with somebody after ACL injury, this is variable, but could be anywhere from 6 weeks to 3 months to sometimes even longer if you have a really swollen and metabolically active joint. So when those symptoms are present in your patients, then the autogenic reflex response site that I define as arthrogenic muscle inhibition is present, and the quadriceps muscle will not contract. Over time, what happens is, as we rehab participants or rehab patients in the first few months of their recovery, and we're treating swelling, but still trying to get, restore full extension, knee range motion, strengthen the quadriceps muscle to get it back. We ingrain or entrain those motor units that are active early in rehab, and the ones that are masked by the inhibition are unable to be trained. That is then kind of ingrained in the nervous system, as Dan, you alluded to, the level of the cortex, then kind of unlearns how to contract those muscles. So after 3 months, when the peripheral symptoms are gone, we still see this persistent muscle weakness that's kind of non-responsive to our traditional strength training approaches. And that's really ingrained by cortical level inhibition at that point.
Yeah. And certainly, again, that's the frustrating part for us, right? Is, if you've done the basics well and you've restored motion and attempted to manage swelling and everything, but there's still some of those detrimental effects of the AMI, right? It really, I feel like, inhibits what they can do as far as progressions functionally, especially as we get into more closed chain things. And return to sports stuff for sure. But we'll get into more of that a little bit later. What I'm wondering if you could answer for us, Dave, is what do you think? Is there a factor, or is there anything that potentially makes one individual more susceptible to some of these changes than another? And because I see it all the time, you'll have the patient that can't do a straight leg raise for 3 weeks, right? And then you have the patient that gets it without a lag after 3 days. So what do you think accounts for the variability between people or between patients with that?
It's a great question. I wish I knew the answer to that. From the foundations of the condition, I would say it has to do with the level of excitation of the sensory neuron. So from a clinical perspective, that would be the amount of effusion in the joint, the amount of swelling or the damage done intraoperatively or prior to that with the surgery or injury itself, is going to drive the level of activation of that reflex loop and the amount of inhibition on the other side. Now, that being said, synapses are completely plastic. They're very easy and sometimes, most of the time, easy to change their synaptic strength. And so some patients may learn to overcome inhibition through various means better than other patients. It's difficult to say, and why there's such a clinical interest in developing kind of a grading scale or a scoring system for assessing the level of inhibition in the clinic. Unfortunately, I have to say there's no validated way to do that yet, but we are.
Beat me to that question.
We are working on it, and we can talk more about it when that question comes up.
Sure.
But yeah, as far as the varied response or the magnitude of the response from one patient to the next, it's difficult to attribute that to any one source. However, I would encourage patients to assume that inhibition is there, and for a number of reasons, it's difficult to diagnose, and it's very easy to treat if we assume it's there.
For sure. Okay. So on that note, that's a good say. Do you, in your research, and again, I don't know your research or someone else's, since you're definitely more well-informed in this area, in this wheelhouse here, is there anything you've identified prospectively that kind of clues us in? Is there a marker or a clinical indicator preoperatively for who you think might struggle postoperatively most with it?
The best predictor of postoperative success as far as quadriceps strength goes is preoperative quadriceps strength. So if somebody has struggled with pain or swelling in the preoperative period, or has a lot of muscle inhibition and poor motor control of the quadriceps, they're most likely going to be the person that the AMI is re-aggravated in postoperatively. So addressing to the extent that you're able to in your patients, if you see them preoperatively, addressing those impairments preoperatively is always a good idea.
Yeah, great. you just mentioned it, right? There's no kind of verified, valid clinical tool or assessment tool to kind of clinically identify it. But in your research, what are you using to really identify when AMI is present, and what kind of lab tools or markers are you using to designate it?
Yeah, on the laboratory side of things, we get pretty sophisticated in our neurophysiology techniques.
Yeah.
We're using peripheral stimulation and characterizing the strength of the reflex, basically the surrogate for a tendon tap reflex, and actually quantifying how much of the motor neuron pool is available to these patients and how much is masked by inhibition. We're using transcranial magnetic stimulation, or TMS, to stimulate the corticospinal tract, or basically fire neurons in somebody's brain, and measure the excitability of the muscle at the end of the efferent pathway. And a few different techniques in between, as well as muscle and looking at volitional muscle activation through what's called the superimposed burst technique, or the interpolated twitch technique, where we ask somebody to fully contract their quadriceps muscle by doing a MVIC for knee extension, and then we deliver 360 milliamps of current through the muscle to contract the muscle fully and see what the difference was between their volitional activation and their innate muscle capacity, as far as what is the cross-sectional area or muscle volume going to be able to generate for them.
Okay.
Those, by the way, not to interrupt.
Yeah, go for it.
I do not expect those to be accessible to a clinician in the clinic. They take quite a lot of training and expensive equipment. And so we're working on ways, think about it as like a clinical prediction rule.
Yeah.
We use these for DVTs and other examples in medicine by saying, here's a clinical presentation. How well does that map onto some gold standard assessment?
Yeah.
And that way we empower you, the clinician, to diagnose and maybe grade arthrogenic muscle inhibition in a way that's validated against a gold standard.
Perfect. That was going to be one of my questions. I know it sounded like you may have something in process, right? When you said there's no current tool, but
right. We're working on it.
All right. Excellent. So that's probably a good question. Like, once we've identified it, how modifiable is it? And I want to get into some of the intervention side of things also, but how modifiable is it? And at what time point would you say it's kind of most malleable or open to some sort of remediation or treatment?
Yeah, great. So it's very plastic. Any synaptic strength is plastic in the long term, or able to be modulated in the short term through a number of different techniques. The first study to really show how modifiable arthrogenic muscle inhibition is was about, I think, published in 2001, Hopkins and Ingersoll. And they use an effusion model and an experimental pain model in which they injected the knee joints of healthy people with saline to distend the joint capsule. That reduces the quadriceps excitability in the short term. And then they intervened with cryotherapy, focal joint cooling, half or a third of the group. A third of the group got TENS, transcutaneous electrical nerve stimulation. And then another third of the group got nothing. They just watched how their reflex changed. And effusion doesn't stay in the joint very long, especially when you start to move, but inhibition was present for about an hour after an artificial injection. Okay. So that shows you how transient inhibition might be when swelling resolves, right? And you're getting rid of the problem in the first place. The patients who got TENS saw no change in their reflex excitability, meaning that TENS almost preserved their access. Even though the joint was swollen, they were still able to contract their quadriceps muscle to the same extent because of what we think of as the gate control theory. So although the swelling, the receptors that are sensing swelling in the joint were firing, their activity was masked by the TENS. And then the group that did best was the group that got focal joint cooling or cryotherapy. The knee joint itself was iced down, and their reflex response actually increased, even though they had swelling. Okay, and I mentioned this basic work because it tells us two things. It tells us that this is a normal response. The interventions that treat the source of the problem, being the activity of the receptors sensing swelling in the joint, are going to be effective, and that those interventions are their effectiveness itself will be transient. So there's like an hour or 45-minute long therapeutic window after you deliver one of these interventions that you want to capitalize on this stuff. And these two interventions, TENS and focal joint cooling, come up a lot from that paper on to the next 20 years. Some applied in the knee osteoarthritis literature, some applied in the ACL literature. And the most promising effect that I've seen was a paper in 2014, Joe Hart and his colleagues in the Journal of Athletic Training. They did a 2-week randomized control trial where they had 3 groups. The first group did just exercise. Oh, by the way, these patients were after ACL injury. They were all at least 6 months out of their injury and returned to sport. And they had persistent muscle inhibition. So this is after a period of physical rehabilitation. They're back playing sport, and their quadriceps are still weak. So I would say that's pretty much the standard case or standard outcome.
Yeah. Typical presentation.
Right, typical presentation. And they take they have 3 groups in this randomized control trial. One gets 2 weeks of strength training exercise, one gets just cryotherapy for 2 weeks, and one does cryotherapy and then exercise for 2 weeks. And the group that got the cryotherapy intervention and the strength training improved their strength 38% in just the 2 weeks of strength and conditioning. And that, if I could tell you that if you were to go and do 2 weeks of a workout and increase your strength 38%, you'd be sold.
Yeah.
Right. Yeah. And so that just serves to show that inhibition is probably present longer than we think it is, and addressing the source of inhibition and using that therapeutic window can be very beneficial. When it comes to long-term, like resolving inhibition in the long term, that's where we still need to make some progress. And it's difficult to say which interventions are going to solve this problem as opposed to just unmask it during a therapeutic window. But there's a lot of implications for doing that effectively in rehab and addressing it in the short term, because you improve your outcomes, you improve strength, and you avoid the secondary impact of not using a muscle for 6 months, right? Where the muscle starts to atrophy, it gets fatty infiltrate, and its capacity is the ceiling of its function is going to drop.
And to correct me if I'm wrong, I wanted to dive more into the specifics of that study and the research protocol. But I believe they implemented the cryotherapy at the beginning of the start of the treatment, right? For 20 minutes prior to starting exercise, right? That improved the excitement. Okay. All right.
When I mention ice and exercise, I don't mean ice after exercise. I mean ice and then exercise.
And then,
So it flips the paradigm on its head. I'm not getting into the should we ice after our patients after therapy debate. I don't.
We'll save that for another podcast.
I don't want to weigh in there. I want you to ice your patients on their way to therapy or at the beginning of physical therapy, as a way to modulate the nervous system and prepare them for exercise. And I know it has implications for muscle warming, and you want your patients to be warm and active and prepared to exercise. I get that, but these patients have a sick joint, and we need to cool it down in order to modulate the nervous system in a way to help the muscle, which is what we intervene on in rehab, is the muscle.
All right. Awesome. So in terms of overarching principles, I guess, so segueing off of that, right? Do you feel like should we treat the pain and effusion first, and worry a little less about strengthening until pain and effusion are controlled? Or I guess I'm wondering, is there kind of an ideal overarching concept or principle that you would take? We'll focus on ACL specifically, but this I feel like applies to total knees. There's a lot of general applicability as well, but I'll let you kind of give your thoughts as far as what do you think the focus should be or the priorities.
Yeah, we have to do the basics well. And the basics with a patient who's just had a knee injury, and specifically a knee surgery, is you have to recover range of motion, you have to reduce swelling, and you have to reduce pain. Those should be the priorities. And if you're doing those well, you're recovering terminal knee extension quickly, there's no reason why quadricep strengthening should be contraindicated, especially in the traditional sense where you're doing quad sets or NMES, especially NMES, in order to preserve or reactivate a muscle after surgery. Okay, we've all seen these patients. You get them within a week of their surgery. Some of them are still sick, nauseous. Focus they can only deal with a few things, send them home with knowing I need to keep my knee straight and start to recover range of motion. As they can tolerate it, get the muscle active, and send them home with an NMES unit to do some of the work for them. The NMES has many different neuromuscular electrical stimulation. Sorry, I'm speaking in acronym.
Yeah, sorry. I think most of our audience will be able to kind of decipher that one.
Neuromuscular electrical stimulation has many implications after knee joint surgery, and it should almost always be used if a patient can tolerate it. And for the most part, just in very simple terms, it preserves a patient's muscle function in the period where they're not using that muscle function themselves. Okay, so it helps to prevent the effects of say immobilization, right, or non-use or disuse in that acute postoperative period. And then as they get farther out, it has, and you can turn up the intensity more and do more functional exercises with it. It has even greater benefits than that. But just as a way to preserve muscle function, that's the way I think of NMES in the acute postoperative period, and it is absolutely indicated and should be used. And then volitional contraction to the extent that to get back to your original question, what should we be focusing on? To the extent that they can handle it, moving your focus to quadriceps strengthening as quickly as possible, while preserving terminal knee extension and continuing to push flexion is important.
Yeah. Okay, awesome. Just to revisit the NMES discussion, I know you and I had talked, right? Because Lynn Snyder-Mackler has done a ton of work on this starting in, early or mid 90s all the way through now, right? But it's kind of been rehashed or revisited recently. There have been a couple articles in JOSPT about ideal implementation, ideal parameters. So are you able to kind of give some framework for the listeners as far as what's the ideal, maybe, I mean, most of the NMES units are going to have their kind of default settings. I guess the question is, do you feel like those are adequate, and what should we tweak or titrate as far as time on, time off? And maybe we can get into talk about positioning a little bit also, but I'll save that. I'll let you kind of give your thoughts first, and then we'll get into that.
So the paper you're referring to is Who's Afraid of the Big Bad, or Who's Afraid of Electrical Stimulation?
Correct. Yes.
It's an excellent paper. Alana Arhos, I think, was the lead author there. And y'all should read it. It's great. It compares clinical electrical stimulators under the commonly cited barrier that these are not strong enough to have a favorable effect on our patients. And they address that head on and say, although somewhat true, something is better than nothing. And the number one threat to the use of NMES is adoption in the clinic and prescription at home. And something is better than nothing. Take-home message, I think, to answer your question is you should be using NMES units after surgery.
Yeah.
The second question is whether or not the default parameters or the way we use NMES is optimized for improving quadriceps strength or optimizing patient comfort. And that's where I start to get interested, right? This technology is 30, 40 years old. We've been doing Russian stimulation and various types of neuromuscular electrical stimulation for a long time, with very limited innovation surrounding how it can be applied for our orthopedic patients and optimized. And that has a lot to do with improving compliance. But NMES is painful if you're doing it right and you're using it effectively. And so patients often will discontinue use as soon as they can. Therapists are hesitant about prescribing it because there maybe are a lot of different parameters. Where do I place the pads? Are these pads big enough? What's pulse width? What's frequency? How long do I turn up the intensity? What's the duty cycle supposed to be? All these parameters offer opportunities for error or misuse. And we can start to use technology and advancements in technology to reduce the amount of confusion and variability there, and really zero in on what's optimal for this patient in front of me as part of their what's going to contract the muscle most vigorously, what's going to be most tolerable from a pain perspective, and how do I reduce the amount of questions or buttons or knobs that a physical therapist needs to twist in order to get there. And I think all that stuff is what interests me in my work in the lab at Northeastern.
Yeah. Okay. You and I kind of talked off script here a little bit about some work that you're doing. Are you able to share some of that as far as what some of your research is with respect to home NMES units? And
yeah, sure.
Okay. I'll give you the opportunity to give some insight there.
So it kind of takes two new approaches to NMES. The first is not new, and we certainly didn't come up with it. It's something called multi-path simulation. First reported maybe a little over 10 years ago. I forget where the technology came from. I apologize. But this idea of when we use a NMES unit in the clinic, we normally do it using two stimulation pads with a single cable, meaning that there's a single electrical circuit connecting those two pads. And as the electrical current travels through the muscle, it's going to travel through more or less the same motor units and muscle fibers every time it ramps up, holds, and then ramps down. And so that has implications for how much of the muscle we're actually training during an NMES intervention, how quickly fatigue sets in during that session, et cetera. And multi-path stimulation is really increasing the number of pads placed on the muscle, and therefore increasing the degrees of freedom that we can vary the direction of the current. So instead of the 2-pad setup where the current always goes from A to B, you'd have, for example, a 4-pad setup where during the first contraction or the first portion of the first contraction, I just got balloons everywhere.
I see that. I was wondering. I was like, wow. Yeah. All right. Yeah. Added effects. Who said we're low tech and low budget here for this podcast?
That sounds pretty
right.
That's pretty sweet. So instead of going from A to B for every different cycle of the contraction, we can go from pad A to B on the first half of the first contraction, then C to D, then A to C, then C to B, then A to D, and vary it so that the current is going through different motor units, different muscle fibers during a given treatment session. Helps to preserve more of that muscle function by contracting an unrecruited portion of the muscle, and reduce fatigue and improve comfort by spreading the current density apart. Through a wider proportion of the muscle. So that's one area of innovation, and we're studying the neurophysiology of that and how it influences motor unit retention and all this stuff in the lab. The second component is with the other parameters, so not just pad location, but in current direction, but what about pulse width and frequency, and how does that balance out with intensity? And is there an area of the strength duration curve, which is how motor neurons are selectively sensitive to electrical current? Is there a specific area of that's optimized for this patient on this table and this patient on that table? And can we take the decision-making out of a physical therapist's hands using things like machine learning or artificial intelligence?
Okay. Sounds super promising and super helpful. If we could, to be determined, right? But definitely an interesting concept. But I wanted to, for the day-to-day, everyday clinician that might be listening, one of the controversies that I know that's kind of stemmed from the Who's Afraid of the Big Bad Wolf NMES paper was whether or not there should be a volitional contraction during NMES application. And I wanted to kind of get your thoughts as far as kind of actively participating versus passive, because I believe, correct me if I'm wrong, the overarching recommendation from that was there should not be a volitional contraction during it because it may kind of limit the effectiveness of the NMES application. But at the same time, we've seen protocols where you're potentially enhancing the effectiveness of the NMES and quad activation by doing it with like an open chain isometric contraction at, let's say, 60 degrees, that kind of thing. So what are your thoughts about that? Does it matter? And is there kind of an ideal implementation or position for the most effective treatment?
Yeah, I think it's really a preference thing. Co-contraction is going to potentially for some patients, improve their comfort. Others make it less tolerable. I always go back to neurophysiology. I'm a nerd in that way. And I think about...
We love nerds on this podcast. So you're in the right place. Yeah.
Good.
Yeah.
Good. I found my home. The way we recruit a muscle during a volitional contraction is we tend to recruit smaller motor units that fire more quickly first. And then as the strength of our contraction increases, start to get those mid-size, more slower firing, and then eventually those really large, slow firing motor units, okay? Those more fast fatigable motor units.
Right.
NMES works the opposite way. So where we kind of ramp up, NMES comes from the top down, and it's recruiting those large motor units that would otherwise go unrecruited in our patients first, and then working its way down as we increase the intensity of the stimulation. And so co-contraction really serves to recruit more of the muscle capacity, being that a co-contraction is the only thing that's going to get the smaller motor units recruited. And that's and so is it better to do NMES without co-contraction and get the larger motor units during a kind of more of a passive session multiple times a day? Or can we overlay it with rehab where we're already doing our quad sets and our strength leg raises that are going to be using more of those smaller muscle fibers? I would say that, like, I'm going to stay out of the debate and just say you should use it.
Yes.
Use NMES because there's no way our straight leg raises or quad contractions are doing the work that the NMES unit does.
For sure.
Now, I'll caveat that and say blood flow restriction does kind of get at that a little bit with its metabolic stress to the muscle, and getting at some of the same muscle fibers, motor units that NMES would get at to some extent. So,
do you feel though that there's a difference between kind of the metabolic physiological effects on the muscle versus the more neural pathway that you're going to get with NMES between the two? Is there one that's kind of super? I mean, disclaimer again, I use them both, but do you feel like if clinician could only choose one, what would kind of give you the most bang for your buck, I guess?
I would think that NMES is the more tried and true evidence-based method at this point. The blood flow restriction evidence is a little bit mixed.
Yes, especially with ACL, there's been a bunch of stuff that's come out recently, right? Yeah,
is a little bit mixed, although there are a few studies that combine them both, use blood flow restriction and NMES on the same patients at the same time. And I feel very badly for those research participants. That's really
super sore the next day.
But it does suggest some added benefit, meaning, or suggesting to me at least that there's different mechanistic pathways between the two modalities. So there is benefit to using them both.
Okay.
But I would think, like, if you, again, I'm back to the basics before you worry about any of the research that I do.
Sure.
Make sure we're doing the basics well, and that would be using the past 40 years of evidence to say that NMES should be used in these patients and be beneficial to these patients. So,
and get full extension motion.
Right.
Yeah.
Retain it as much as possible.
Okay, so just to pick up on that, because we mentioned the benefits of cryotherapy and ice application. Do you have any thoughts on kind of additive benefits or enhanced effects of some of the more commercial cryotherapy units like Game Ready? Not to exclude any particular brands or that kind of thing, but just off the top of my head, Game Ready, Polar Care, Ice Band, those kind of things. Do you perceive any added benefit that you've seen from a research standpoint or with respect especially to muscle excitability or more effectively addressing inhibition?
I'll just say I'm not aware of any evidence that uses those modalities as a focal joint cooling or cryotherapy intervention.
Okay.
I'd love to read the papers if they're out there. However, like I mentioned, the clinical signs that contribute to arthrogenic muscle inhibition are swelling and pain. Compression, elevation, and ice, being these like Game Ready like systems, address pain and
all of this
swelling through compression. And normally a patient is like lying down with their leg elevated.
Yep.
That being said, like if all you have is an ice bag and a patient needs to say ice on their way to therapy to preserve your time in physical therapy instead of sitting for 20 minutes at the start of their treatment and wasting that time where they could be exercising, then I would say the old ice bag that's going to melt after 20 minutes is probably the best, most accessible treatment for this. What really amounts to neuromodulation before orthopedic intervention. So I would say don't overcomplicate it with these systems if it's not necessary. In the absence of evidence to the contrary, I would say, focal joint cooling or cryotherapy prior to exercise in any way that's accessible to your patients is a good thing to start to implement.
Yeah. Frozen peas are cheap, but effective, right?
Yeah, effective.
Just don't eat them afterwards, right? But yeah. All right. But they contour and mold really well to the joint. So,
they do. Absolutely.
Yeah. So just to shift gears for a minute, Dave, because I want to kind of try to tap into as many of your insights as we can here. We focused a lot on early part of rehab and what we can do in the early stages, but you mentioned kind of the persistence of AMI for some folks later into the rehab, and a big, again, recent research niche is rate of force development, right? Rate of torque, that kind of thing, and the difficulty with recovering that, especially, again, most of the research has been done in ACL subjects, right, or ACL reconstructed subjects. So one of the difficulties we have is, first off, measuring it, right? And I know I've talked to many clinicians that say that measuring it kind of in clinic is super hard unless you have an isokinetic dynamometer, right? Because the kind of give in the system, if there's any give in the pads or that kind of thing, it affects or significantly impacts the accuracy of the reading, right? So first off, I guess, so I want to ask you, how do you identify it? Is there a best way to do it? And I also want to get into training it and how we can possibly overcome some of the negative or detrimental effects of AMI that we already discussed.
Yeah, that's a good question. So the rate of force development gets at the fact that we've been quite focused on maximum strength or maximum volitional strength for a long time. That's just peak force. How strong is somebody? What's their limb symmetry index? And this is an oversimplification of how a muscle functions. Other areas of research beyond rate of force development are like torque steadiness and how stable can somebody hold the force at a given intensity. But I like rate of force development because it adds the power component. And we just talked about how some of the motor units that are lost or at least inhibited early on after ACL reconstruction are those fast, fatigable, large motor units that are responsible for generating force very rapidly. If those are the ones that are inhibited and those are the ones that are most likely to become pruned or catabolized throughout recovery, you're going to have a lasting impact on rate of force development and the amount of muscle power you can generate. Assessing that isometrically, as you mentioned, is difficult in the clinic because right now, and I'm very happy to see the Tyndek devices being everywhere now in the clinic. This little $200 gizmo that you can attach in line with a strength test, and it will record in newtons the force output. If you set it up correctly, then rate of force development should not be completely obsolete in that setup. And there's some evidence to say that this can be a reliable setup for the acquisition of this type of data. But the clinician should know that it must be set up with very high fidelity in test and retest situations and between patients in order to acquire reliable data. And the most reliable in that environment is always going to be the 20%. So the software in the Tyndek, as far as since the last time I checked, looks at the start of a contraction to the peak and then takes the 20% to 80% of the portion of that in the slope between those 2 points. And I think that's pretty robust to lack of tension in the system at the beginning or some of these little flaws. So if you're not measuring it, I think you're going to miss it, but you have to measure it reliably in order to know that the impairment's there and to monitor changes with your treatment over time. So I think, again, it's like, this is all fun to talk about, but are we doing the basics well? Are you at least recording peak torque, using something more than a manual muscle test?
Yeah.
Right. Are we looking at that both
Hopefully.
in limb symmetry, but also in relation to Newton meters per kilogram, or allometrically scaled to the person's body weight against a reference standard? These are like, as we're raising the bar on treatment, these are the steps that we have to take before we worry about things like rate of force development broadly in your everyday clinic.
Yeah.
As far as treating rate of force development goes, or intervening on it, that's where your velocity-based training comes in, or your power-based training comes in. These not very high load, but very high velocity movements, these powerful movements that you're doing very few of. Plyometrics is a good example of that.
Right.
And then getting into more functional tasks as well. Once you start to close the gap on any deficits, and you've done your knee extension isolated knee extension, which absolutely everyone should do, and done that in a capacity of velocity-based training and power-based training, then you start to get in things like single leg vertical jump being a very good and reliable indicator of single limb power, like triple extension. How high can the participant jump on one leg compared to the other side?
And more quad dominant than some of the horizontal hop tests, kind of thing, right? Yeah. So
it's all about optimization, and are we measuring in a valid and reliable way the things that are meaningful, ecologically valid to what the patient's going to have to do when they step back out on the court or onto the field.
Yeah. Okay. Great. Do you feel like, is there an optimal time frame, again, aside from when pain is resolved, swelling is controlled or resolved? Is there an optimal time frame or strength benchmark where you feel like you should hit this before you begin some of that velocity-based training, or do you feel like actually beginning it earlier in the rehab to activate some of those motor units that you might not be able to access is beneficial? Like, what are your thoughts on that?
It's a good question. So I don't know if I have a formalized
concrete thought
equation on this. I would say that last year at CSM, Megan Graham gave a great talk during her quad squad session. That covered some of this velocity-based training and when they started it at the University of Kentucky, where she works. So I would ask, I think there's recording, or at least the slides are available if you attended last year, and I have them if you want to reach out to me, or Megan, I'm sure, has them as well. But that's a great resource for answers to this question.
Awesome.
I would say it's a double-edged sword where you don't want to start too soon, where you need to start to build comfort with this type of contraction before you really push it. But you also don't want to wait too long. If you're always waiting to get at least, say, 80% limb symmetry, that could be 6 months or a year.
Right.
And at that point, it's going to become harder to recover your fast twitch muscle fibers, large motor units. So you have to train it early, but the patient needs to be oriented to it. And again, like, we go back to having the priorities in order here with the basics. Do the basics well, build strength, make sure that you have a pain-free joint with no swelling, there's full range of motion, and then we can get fancy with our interventions.
Yeah. So on that note, I want to pick up on one more thing you just kind of loosely alluded to. When some of those inhibition effects are present for longer or more chronic or persistent, is there a window where there's a drop off, or where kind of a point of no return, where once it's present for this long, it's kind of there for good?
We're not there for good.
Got it. Okay. Yeah. Okay.
We have a paper published in Peer J last year that talks about this a little bit, tries to get at, is the motor neuron pool or the available motor units in the muscle diminished long-term after ACL? And long-term in our sample was 6 months to 2 years post-operative. That doesn't answer the question of, is it recoverable? But we have another paper that kind of, with it in a different sample of participants, that supports that result and conclusion that there's a limited number of motor units available to these participants, even up to 2 years out. but it doesn't answer the question of can we intervene on it and improve that situation for them. I will say that if you look at literature from other neurologic populations, like in patients with ALS, for example, there's denervation of muscle, very common in these conditions, the primary impairment in these conditions, and then periods of like relative remission where there's reinnervation of muscle. And every time it goes through one of these denervation, reinnervation cycles, there's fewer motor units available. Whether or not that's true for like ACL injury, to be determined.
Yeah.
But that's the way I start to think of this is every insult that they have. So if it's a primary injury and then a reconstruction and then a re-tear and then another reconstruction or another surgery, I think the cards are just being stacked against them in that environment, in that situation. So the ceiling of muscle function, I would view as, I take a kind of a negative outlook on this, but intervening early is the best way to combat that.
Got it.
Yeah.
Do you perceive, because there have been a number of studies looking at, especially in professional athletes, looking at performance deficits in that first year after coming back with return to sport, right? Do you perceive that there's a correlation between some of the inability to access some of those fast twitch rate of force development muscle units or motor units that you just alluded to, and that performance deficit, that kind of lack of explosiveness or that kind of thing in the first year?
I would be hesitant to oversimplify it in that way. I think there's a strong correlation between how strong somebody's quadriceps is and how they feel about their knee.
Okay.
And how confident in their knee they are when they're out on the field. However, when you're talking about athletic performance, that is like so multifactorial that I wouldn't be vain enough to think that what I'm interested in, quadricep strength, is that important.
Is the sole determinant?
Yeah.
Okay.
So I think it has to do with all the psychological components of recovery, the fact that they've been out of training with their team and teammates for 6 to 9 months, sometimes a year, and just kind of needing some time to get back into it at a high level. And not everyone's that way. Some people do very well very early, but it's so multifaceted. Neurocognitive components that Dustin Grooms and Meredith Chaput study. I mean, all of these, learned helplessness at a UConn. All of these play a role in how a patient feels when they step back out on the court, and therefore how they play.
Yeah.
I don't think quadricep strength is that is the be all end all of their success.
Sort of. Okay.
Yep.
Thank you very much. This has been awesome and hugely insightful. And I feel like, it makes me feel like I need to go back and study my neuro a little more.
Please do. Yeah.
But so for anyone else that's kind of captivated and interested by this, where can any listeners here find out more about you and about your work or reach you?
Yeah, so most of my science communication is done through our physical therapy business, Live4 Physical Therapy in Acton, Mass. You can find us at live4pt.com. I post intermittently on a blog there about some of our research. And then you can always look me up or contact me at Northeastern University. And we're in the Movement Neuroscience Laboratory at Northeastern.
Awesome.
Yep.
So just to finish up, throw you a little curveball here, if we could. That again was off script here. If you could tell us a little bit of something about you that might not be in your Northeastern bio page. Tell us about any hobbies or interests you have for the listeners.
I was just telling you how we had to take the stairs because I don't get a chance to exercise.
Oh, please.
So
yes.
I have a 1.5-year-old at home. My wife and I have a 1.5-year-old at home. We spend a lot of time with them. And family's very important. We're here back in Rhode Island because I have a very large family. So most of the weekends are spent here in this area with my nephew, who's a 1.5 years, my brother, sister, and in-laws. So that's about it. That's
right. Awesome.
And struggling to fit a run in every once.
Yeah, right. It's a struggle. Right? Like I said, there's definitely value in the gym-based daycare facilities for for a small period, right? So, all right, awesome. Well, thank you again for joining. This has been great, and you've been an awesome guest. And I feel like we only tapped into a little bit of some of your research areas and that kind of thing, but I feel like I could talk another hour, but we'll have to have you back for a repeat performance some point down the road.
Happy to do it. Yeah.
All right.
Thanks for having me.
Thank you very much, Dave. Take care. Have a great day.
Yeah. Bye.